mission is to empower women that are navigating this transformative phase with confidence and knowledge and lots of education. And we're hosting this webinar because perimenopause and PCOS are two things that are not often discussed together, are briefly discussed, if anything at all. And then talking about them in conjunction, it's pretty rare. So these are two complex phases that many women navigate, and there's a lot of there's lack of information and research in this space, and this leaves a lot of women underserved with more questions than answers. So we wanted to discuss a little bit more and bring more insights and knowledge to women about PCOS in perimenopause. And before we start, just a PSA for this group, everything that we're going to be, excuse me, discussing is for educational purposes, so it should not be taken as individual medical advice. As we go through the questions with Dr. Faris, please feel free to drop your questions in the chat, and we're going to be addressing them at the end of the conversation. And we're going to be recording this session, so this will be shared afterwards via email with the people here and the people that signed up. And I did not introduce myself. I'm Marina Penn. I'm co-founder of Navi, and we have here EJ Kim, who's co-founder of Navi as well. And we have with us Dr. Basma Faris, who is an expert in women's health. She specializes in the intersection of PCOS, metabolic health, and hormonal transitions. She's a board-certified OB-GYN. She's an expert in nutrition, and she's a highly regarded speaker and educator in all things hormonal changes, perimenopause, PCOS. And she's a champion of empowering women to understand the needs that occur during this time, during these phases, and advocate for themselves. And we're going to be talking a lot about that tonight. So welcome, Dr. Faris, and thank you so much for joining us tonight.
What an introduction. Thank you so much. We are aligned in our missions, right? To educate women and empower women to understand their bodies and understand how to care for themselves in this time. You know, in the last few years, social media has really allowed women to learn so much about their own bodies. But I fear, you know, in the current climate here in the United States, getting reliable information may be challenged. This on this mission to continue to educate the conversations open. And so that's what we're to do today, right? So thank you so much for having me.
Yeah, thanks for joining us. So we're going to kick off with some questions for you, Dr. Faris. And EJ, do you want to go through questions? You feel good with that?
Absolutely. So, Dr. Ferris, so I was so excited to be here to ask all these questions because I am that woman who has both PCOS and I'm in peri. And I don't know how many people who are listening right now, you know, falls into that category, but there are actually many of us out there. You know, PCOS was something that I kind of again learned by accident in my 30s when I was looking into kind of fertility and that going through all that. And you know, it was very interesting because the more I learned, everything makes sense in my teens and tweens. But then I was already in late 30s trying to understand what my body was capable of or not. So I think just to benefit everybody though, we'd love to start with the definition. So do
Yeah.
you mind kind of give us a 101 on definition of what PCOS stands for, what it is, and then we can talk about perimenopause so we can have a grounding and everybody has the same understanding to start the conversation.
Perfect. Yes, so let's start with the definitions. PCOS, for those of you who don't know, stands for polycystic ovarian syndrome. It's a lousy name for the condition, but it does refer to the ovary and, function and how it impacts the function of the ovaries. The name originally came from this characteristic appearance on ultrasound that can be seen where the ovaries all very small cysts that house our eggs. These are called follicles. And so that's where the name polycystic ovarian syndrome came from. But it is a multi-organ or multi-system chronic medical condition that affects the women's reproductive system. So the ovarian function, in terms of the hormones it produces, in terms of ovulation, and it impacts multi cardiovascular health, metabolic health, and underlying this problem with the ovaries or this dysfunction in the ovaries for most people are other hormonal disorders. So for most people, that means some insulin resistance. So that's the endocrine system or hormonal system that helps to manage how we utilize. So it may involve the adrenal glands and some of the adrenal hormones. So the adrenal glands are the hormone that is the gland that is responsible for producing cortisol, which is probably amongst other hormones, it's probably the one that people are most.
I think her connection's spotty. I just want to make sure, is it me or everyone else
Yeah.
experienced the same?
Yeah,
Are you hearing me?
Yeah, it
Good.
was kind of
Yeah.
in and out. Let's
Okay.
try.
Yeah, and if you want to go off camera, Dr. Faris, and see if that works better, yeah, we can try that.
But let's try it. Seems
All
clear
right.
now. Go ahead.
And movement. I get very animated when I speak. Can you hear me now?
Yes.
Okay. All right. I'm gonna sit on my hands so I stop moving so much. So PCOS, it's a multi-organ or multi-system chronic medical condition that impacts the ovaries primarily, but also, like I said, the brain, the metabolism, cardiovascular health, um, and also underlying that are some other hormonal abnormalities like insulin resistance and some adrenal glands function and express themselves. People with polycystic ovarian syndrome typically have some changes in their menstrual cycle, often delayed or irregular or long menstrual cycles, and that's a result usually of um, irregular or unpredictable ovulation. People with PCOS also can struggle with having elevated levels of androgens. So these are the hormones that we typically or used to call male hormones, but women make them in abundant amounts as well. But people with PCOS may have them in even higher levels. So they may experience some dermatologic symptoms like acne or facial hair or some balding in what we call a male pattern. Um, People with PCOS can have challenges with their weight, so difficulty losing weight or just finding it very easy to gain weight, even when they haven't made any significant changes in lifestyle. And also the weight distribution may be a bit different with some more abdominal weight gain, and we call visceral fat. So weight gain or fat gain around the middle. And this may all sound familiar because these symptoms can also be symptoms that sometimes people experience in perimenopause, which I think is, part of the reason why we're having this conversation today, because sometimes people will come and say, well, what is it that I'm experiencing? Am I experiencing PCOS or am I experiencing perimenopause? And so let's now define perimenopause. So then we can get back to the conversation about how do we distinguish one from the other? And what happens when you are somebody who has PCOS who is now experiencing perimenopause? So, perimenopause, on the other hand, peri means around the time of menopause. And menopause, so let's get our definitions correct, is when you cease menstruating, when your ovaries stop ovulating. And when somebody has gone an entire year without having a menstrual cycle, they are considered to be in menopause. And perimenopause is the years leading up to menopause, in that year transition, and maybe a few years afterwards, where people can experience lots of different symptoms as a result of their changing hormone levels. And so, um, what I would say that question is kind of touching, going back into what EJ probably experienced is discovering that she had PCOS maybe a little bit later, but then also creeping up on that period going on, thinking about the difference between the two of them in people that don't have either. And then I think that can help us to discuss the overlap. Does that make sense?
Absolutely, doctor. I mean, what is confusing is that PCOS is something that's not people really learn about. You kind of find out that you are. And then I
Mm-hmm.
think the similarity with that, with perimenopause, is that you also kind of walk into it without knowing. And that's kind of why we even established NAVI, because there are a lot of women like ourselves, Marina, EJ, just walked into perimenopause without knowing what it was. So, given some of the symptoms that you highlighted that, people with PCOS can experience, as you said, there are a lot of overlapping symptoms. So I guess we'd love to understand if there's a woman who's just walking into perimenopause without PCOS, but if there's a woman who is walking into perimenopause with PCOS, what are the major difference, would you
Yeah.
say?
Yeah. So let's talk about the woman that walks into perimenopause. And just so everybody understands, perimenopause can start about 10 years prior to menopause. And the normal age of menopause is anywhere from 40 plus, 40 to the late 60s. So somebody could start to be experiencing perimenopausal symptoms really as early as mid 30s, right? Um, and so somebody is starting to experience in menopause some changes in their menstrual cycles. Maybe they're getting shorter at first, maybe they're getting longer, maybe they skip sometimes, maybe some months they're really heavy. People may start to experiencing changes in body composition where the fat distribution is changing in their body, sleep disruptions, mood changes, changes in skin, right? Some dermatologic symptoms, as well as um, brain fog, joint, and all these other myriad of perimenopausal symptoms that people can experience. And if somebody who does not have PCOS is starting to experience this, it is maybe a little bit clearer, right? There's somebody that knew they had normal menstrual at this point. Okay. Now they're in their late 30s and they're experiencing this. This is likely the onset of perimenopause, right? Early perimenopause. Um, and so menstrual cycles may start to be irregular, etc. Then we have the woman who has PCOS and probably experienced some maybe some mood changes, maybe some changes in body composition from their early years, from their teens, their 20s. And so, maybe they had a history of this and now they're starting to, and then they were on some hormonal contraception maybe for a period of time, and they come off hormonal contraception and they're experiencing it again. And they want to know, is this their PCOS or is this perimenopause? Or what I think I'm starting to see more and more is we have people who are on hormonal contraception for many, many years, right? And so maybe they started when they were 20 and they came off when they were 40, right? And if they think back, they say, oh, yeah, well, 20 years ago, I did experience some irregularity and maybe I had some dermatologic symptoms, and now I'm 40 and now I don't know what I have, right? What am I going through? And so I think that's sort of a common thing that we are seeing is that the signs of PCOS were there, but people weren't diagnosed. Unfortunately, many people are just given hormonal contraception as an answer to all of their different disruptions in their reproductive system, whether it be PCOS or pelvic pain or what have you. And now here they are in their 40s coming off contraception either for fertility purposes or just because they don't, aren't in need of it at the moment. And now we're trying to figure out what's going on. So, um, and that's tricky because as we're going to learn in a moment, there are some differences between the person who has PCOS and doesn't as they transition through perimenopause.
Oh gosh, I'm ready for this. But I
Okay,
think
all
I was,
right.
but
Is
I think
everybody caught up? I hope I just want to make
you're still
sure
a little bit
everybody's
in and out.
okay.
But if there's anyone else struggling to, from your end, the audio perspective, also just leave us a message so we can like pause and return if that's helpful.
I'm going
Um,
to take the headphones out and maybe that will help as well because
okay.
I don't know.
Let's
Yeah,
try
we'll
that.
see.
Okay. And you talked about being on the, a lot of times like, I think I was that person. I mean, no, looking back, I was that person who got on a birth control when I was in my teen years because my period was very irregular. Without the explanation, I was told just take this. And then I was on it for like 20 more decades, And in my late 30s, that's when I finally said, okay, no more, because I wanted to understand what my body was capable of. So what are some of the, you can elaborate on what you're about to say, which is the person who has PCOS entering perimenopause and someone who doesn't walking into perimenopause. So what are
Okay.
the big differences? But also as a part of that, if you could highlight some do's and don'ts for these women dealing with PCOS entering perimenopause. What are some of the tips that you can give us?
Could you repeat the question, EJ? Because I
Oh,
didn't hear you.
Oh, okay. Sorry.
It's
So yeah, no, talking about the experience of women who has PCOS, who does not have PCOS walking into peri, like how are their like lives are different, or what are the things that they should be doing or not doing that's different? But also just thinking about the person who has PCOS walking into perimenopause or experiencing perimenopause symptoms, what are the do's and don'ts from a, physician's perspective?
yeah.
Any advice you can give?
So, the first thing is it used to be thought that PCOS of the reproductive years and that um, once menopause happens, people don't have to worry about PCOS anymore. And so that's one thing that I want to, if anything, I want to dispel that. Okay, and so because there are still, as I mentioned, this other organs that are impacted by PCOS beyond just the ovaries. And if people have some abnormalities in their metabolic health or some changes in their adrenal function, that is going to persist despite the menstrual cycles eventually stopping. Now, what we often see in people with PCOS is as they enter their late 30s or their later reproductive years, there's actually a normalizing of the menstrual cycle regularity. And as this isn't universal because we do know there are people with PCOS who actually ovulate pretty regularly. But if somebody had PCOS and they were ovulating very infrequently and irregularly, we start to see a normalization where that now all of a sudden where they weren't able to have spontaneous regular menstrual cycles, now they're coming a bit more regular. And so people think, oh, wow, my PCOS is going away. What is actually happening is that with fewer follicles, fewer eggs left in the ovary is producing less of the hormones that are inhibiting ovulation. So the AMH levels are normalizing. So if we're talking about somebody with PCOS and without at approaching, let's say age 40, right? Early 40s. In the person without PCOS, they're going to see a dramatic decrease in their AMH levels. And the AMH is a hormone that tells us about the ovarian age and the ovarian function and how many eggs are left. Um, it it's been popularized as sort of like a fertility test, and it isn't really a fertility test but it does tell us something about the ovarian function. And as there is an age-related decline in the number and quality of eggs that all women go through, in somebody with PCOS, that number is going to be low. Now, contrast that with the woman or person with polycystic ovarian syndrome who, as part of the condition, as part of all of these follicles that have been recruited in the ovary, they produce more AMH. And that is actually now included as part of the diagnostic criteria that you could use AMH as a surrogate marker instead of a pelvic ultrasound to help diagnose PCOS. So now we're going from somebody who had high levels of AMH, which was interfering ovulation, to somebody now who has a normal range. They're within the normal range and they're having more regular cycles, but it's normal, but it's not normal for their age. And I think that is the piece that sometimes is not so well understood. And so, and it can make things tricky because now we're not really able to use the AMH to diagnose or exclude one or the other, but just keeping in mind that what we would expect for somebody who's 40, 42 years old is that that AMH should actually be on the lower side. And now it's actually in the normal range. And so that can be tricky because then it can make the diagnosis a bit hard. What people with PCOS have to understand, and I don't want anybody to misinterpret this, is that if you are somebody who is struggling with infertility due to PCOS, your menstrual cycle regularity will now maybe make it easier to get pregnant because now you can ovulate more spontaneously, but none of us can escape the age-related decline in quality. So it shouldn't be, you know, that I don't want people to take away that somehow their ovaries are younger or because their AMH is higher than somebody else at the same age, because there still appears to be, that age-related, decline in quality. But spontaneous pregnancy may net easier. And then, so if you think about historically speaking, or even I think there's a story in the Bible, believe me, I'm not an expert on the biblical stories, but of couples who tried for many, many years not to, to have a family, historically before there was fertility treatment. And then they had this sort of, change of life miracle pregnancy and they were able to have a child. I always, in my mind, my clinician mind says, I would. So the difference, this sort of sets up the difference between the person who has PCOS, who is entering perimenopause. Some studies show that people with perimenopause, people with PCOS have a later age of menopause. Other population studies have shown no difference, but in some populations they've observed, a few years difference, and I think that, has something to do with it. And so instead of the person who doesn't have PCOS has first regular cycles, and then they'll start to see a shortening of their menstrual cycles, and then they'll start to see some irregularity and a lengthening and dropping of their menstrual cycles, and they're going to get longer. Go through a slightly different trajectory, whereas their menstrual cycles, if they were irregular or long, will start to actually maybe get shorter, get more regular for a period of time, and then they will start to space out and drop off again, similar to the woman without.
So we will eventually meet. That's what you're
We'll
saying.
eventually meet, correct. Maybe a few years later, but not
Right.
a
Timing
different,
is
not a
little.
decade different, but
Right.
maybe a few years later. So you will eventually meet, but that experience, especially in the early perimenopausal phase or when your peer may be going through it, it may be slightly different, right? Which may be a contrast to somebody with an reproductive condition like due to some ovarian damage, due to endometriosis. So knowing what's going on with your body is really important because it can help you to predict how do we move along through this next phase of life. I think that was a very long answer to
No,
the
thank you.
question.
Thank you.
I hope it shed a little bit of light on that. Um, I want to shift gears to talk about then how somebody with PCOS and entering perimenopause, how do you then navigate this next phase, right?
Perfect.
And you're going to navigate it really like the rest of us. It depends on your goals, right? Are you still in your family building years? Are you deciding that you don't want a family anymore? You're done, or you never wanted them and you're not having them, or you're desiring them and you haven't started, and then you really need to have some assistance. So it really depends on what your goals are. And because people are starting to have families later and later, there's that layer on top of it as well. If you're needing to undergo fertility treatment, just realizing that you come out of fertility treatment and pregnancy, now we're talking a year or two down the line, things are going to be very different now you've got postpartum and perimenopause and PCOS all layered on top of each other, right? So just to throw like another layer into the mix there. But knowing your risks is very important, and whether you are a person with PCOS or not, about your own baseline health risks. And much of this comes from knowing your family history, right? What do people in your family experience? Do they experience certain types of cancer? Do they experience cardiovascular disease, hypertension? Do they experience diabetes, right? Type 2 diabetes. Know that people with polycystic ovarian syndrome are at a higher risk of type 2 diabetes and some other metabolic conditions. And because insulin resistance is a common feature of PCOS, even though it's not part of the diagnostic criteria, it is advised that every single person with PCOS resistance to be screened periodically. Because then, as we shift from the perimenopausal period, the early perimenopausal period, to late perimenopause and beyond, that these risks only increase. So, number one, as you're entering perimenopause, know what your health risks are, because that's really going to dictate everything. A really surprising statistic for people with polycystic ovarian syndrome is that, and this is really in people who haven't had any sort of significant, we didn't do that, until recently, that at least 50% would develop type 2 diabetes by age 40. Huge, staggering statistic. And again, like I said, now that we have a bit more knowledge and prevent, because type 2 diabetes is a preventable or delayed condition. And so I always tell my patients, hey, who cares if you have type 2 diabetes when you're 65? Because all your friends, like everybody will, And so I say that in jest. Obviously, we do all care, but having it when you're 40 is much different, right? Now, right, and all the health implications that go on. The other things that I'm concerned about. So knowing your risk, your cardiovascular disease risk, and your metabolic health risks. Paying attention to your menstrual cycle duration and flow. In perimenopause, people experience changes in their menstrual cycle. The duration of the menstrual period itself, when you're bleeding, may be longer and may be heavier, right? And this can be due to as you have a longer cycle, you're producing more estrogen. That lining is building up a little bit in that first part of in that, pre-ovulatory follicular phase of the cycle. Maybe there's some polyps, maybe there's some fibroids there, okay? But people are women with PCOS because of the production of the androgen. So we haven't really spoken about this yet. So this is testosterone, which is produced by your ovaries, and DHEAS and androstenedione that are produced by the adrenal glands can be converted into estrogens by there's a enzyme called aromatase that converts the androgens into the estrogens, and it is present in the ovaries, but it's also present in body fat. It's present in many different, so even if the ovaries are not doing their job of converting the testosterone to estrogen appropriately, that excess androgen can be converted by other sites in the body, and that increases the risk of that endometrial lining building up. So if you're somebody with PCOS and you're having very long and very heavy periods when you are having them, that people with PCOS are at a higher risk of what we call endometrial hyperplasia, which is a thickening, an abnormal thickening of the lining of the uterus. They're higher risk for endometrial polyps, which are small little growths in the lining of the uterus, which can cause bleeding. And then both of these can, in time, transform to endometrial cancer. So that's something that doesn't want you definitely ignore, and that becomes more present in the perimenopausal period. And that to me is something that is, if ignored, is preventable and really, really sort of a tragic thing. And I've seen that unfortunately too many times. So those are sort of the things as somebody enters perimenopause. And then I think what everybody sort of wants to know about is weight, changes in body fat distribution, that can occur with both of these scenarios in people with PCOS and in people who are in perimenopause, right? And these are due to changes in insulin sensitivity. This can be changes, increases in chronic inflammation, so inflammatory markers that go along both with PCOS and with perimenopause that can lead us to accumulate around our middles when maybe we had a concern with that. And so that can be, so all the different things, making sure that we have a diet that is rich in antioxidants, making sure that we have a diet that has adequate fiber. Okay, fiber is super important. Minimize or sort of limit the worsening of insulin resistance that goes along with both PCOS and perimenopause, making sure that we maintain our lean body mass. I know there's a lot of attention everywhere you turn. Everybody's talking about protein, protein, protein. But protein does nothing if you're not doing any strength training. So it's not that you just eat more protein and magically you're going to maintain your lean, the strength training to maintain that lean body mass. And then the protein amount that you need is really going to depend on your height and your goals. Are you just trying to maintain? Are you trying to increase your lean body mass so that you can decrease your relative fat mass? And so that's going to really depend on your goals, right? This idea that everybody needs to have, 100 grams of protein a day or 30 grams per meal, I think really there's some nuance that needs to happen there, right? The person who's 5'8" and the person who's 5 feet are not going to have the same nutritional needs. The person that's in the gym lifting for 1 to 2 hours every day is going to be different than somebody who's doing, just sort of body weight strength training or, some resistant bands. So it really is going to depend on people's, again, their exercise, what they're doing, and their goals and their size. But getting adequate protein, getting adequate fiber, and getting adequate antioxidant nutrients. So by just in general getting more fruits and vegetables is going to help if you in perimenopause, whether you have PCOS or not.
That's super helpful because what you say is like, you're right. Like I'm bombarded with this protein message, but you're saying it doesn't do any good if you're not actually strength training. So that's where the whole approaching sort of this as a more holistic lifestyle, not just doing one thing and thinking I check off the box. That's just like entering perimenopause is many things we have to reevaluate, which we talk about a lot in Navi. Actually, Angela's question is similar to mine when you're talking about sort of period being abnormal. Either it's like I've gone through a sort of shorter and longer cycle, but
Yeah.
Angela, so you say how long would you recommend someone with PCOS who's in peri and experiencing long, heavy periods get an ultrasound?
Yeah. So, what is considered to be an abnormal period is a period that is longer than 7 days, or that is heavy to the point that you are soaking through a pad in under an hour for a few hours. If you're experiencing this and you're experiencing it repeatedly, want to bring up to your doctor. Now, in people not yet that should tell us, do we need to do a biopsy or not? Certainly, if somebody has a super, super thick endometrial, we call it an endometrial stripe on sonogram, we'd say, yeah, we probably should sample that. Or we see a polyp and we say, oh, we should remove that polyp. But even if somebody's stripe is within what we call the normal range, but abnormally heavy bleeding, I would still want to evaluate that, right? It's a generally pretty low risk thing to evaluate. And if it means the difference between, intervening in a precancerous condition, versus not, definitely something to, but I wouldn't be, if you had abnormal bleeding and your stripe is normal and they don't want to do any sampling and yet you continue to have abnormal bleeding, I wouldn't be comfortable with that. Um, Now, if it happens, it's a one-off and then you go back to normal, then that's probably okay. But if it's not a one-off and it recurs, then that's something you don't want to ignore.
Angela, just want to make sure if that was helpful. If there's any follow-up question, please feel free to chime in. Small, intimate conversation here, so
Yeah,
let us know.
it's a great
Uh,
question.
Yeah, great question. And you talk about sort of advocating for, yourself, kind of talking about this, because if you're not feeling comfortable, you're not feeling comfortable, regardless the definition of what is normal or abnormal. So I would love to kind of get your guidance on, are there sort of specific people that we should check in with? I mean, obviously your OBGYN, perhaps, but is there anyone in special, like from something abnormal, whether that's period or something feels just not right because you're going through these multiple things at once? What are the sort of your like avengers of your medical support, if you will, that we should be thinking about?
I know it's so tricky because, we've been in this, and I trained in this environment where we didn't learn that much about PCOS and we didn't learn that much about perimenopause or menopause, and so there are still some, and not to the fault of the people who were trained in a certain way, they just didn't learn about something, but. Um, I think if you have a doctor, a clinic doctor or a midwife or nurse practitioner, whoever is your women's health care provider, who, even if they don't know something, who doesn't speak in absolutes, who's curious, who's open to the possibility of finding out more, of talking to a colleague, or who doesn't, maybe if they don't know, they don't feel intimidated by you having another opinion, or even for them to send you for another opinion, right? Then I think that really engenders trust, right? And so if I um, that I know and trust and know they're my patient. So if you find that whoever is taking care of you is rigid, that's not occurring, or no, there's nothing else to do, that to me is a red flag. because we all don't know everything. And understanding that we don't know everything leads us to be curious and leads us to not dismiss our patient's symptoms. And so I think that's very important. And it's a mindset shift that even I had to go through as a clinician. I can't say I was always like that in my early days of practicing. But, you know, being part of being a doctor, right, is that it's a life of learning. So be expected to always practice the same way my whole life. And that means maybe I'm missing something and I'm open to my patients to seek out other opinions and then we can talk about it, right? And we can talk about, yeah, this sounds reasonable. This sounds like not reasonable. This sounds like a red flag. Because then the flip side of that is unfortunately, because there are so many open questions, there's a lot of people out there that prey on those gaps. And people that don't have that much really shouldn't be giving advice but are very free with the advice and there's a lot of people that prey on people and their vulnerabilities or their lack of being able to get answers from their clinicians. And so if you can find yourself somebody who at least is open, right? And even if they say, hey, I don't feel comfortable with that, but I will ask somebody else who I know is more knowledgeable than me, or I will refer you to somebody who I know and trust is an expert in that space, then I think that's a good clinician for you, right? You feel confident that you are in their care. So I think that's just a long way of saying rigid. Maybe you need to find somebody else, even if they don't know all the answers.
Mm-hmm.
And somebody that's going to listen and help you sort through what's real and what's wellness grifting and what's, who's just really trying to take advantage of you and your vulnerabilities.
No, thank you for that. I do have a question about sort of, you talked a lot about obviously eating a lot of protein, fiber, moving, strength training. So those are the like lifestyle adjustment.
Mhm.
But from a like
And sleep.
supplements, I'm sorry.
And sleep.
Oh, of course, sleep. But then also from a either kind of like medications or supplements, because I've been that person where I've been recommended from doctors like, oh, someone like you should take blank. And I guess from your perspective, what are some of the kind of common, usual things that pop up as an option for people to either over the counter or something more, medication perspective? Want to get your thoughts on that, and then I want to throw as a part of the like metformin. I think it's like the very popular. And then also like now with the GLP-1, I mean, there's a lot there. So I know I'm throwing a lot at you. And then we're going to go to
Oh,
Jack's
it's an
question,
excellent
but yeah, I
question.
would love to hear your perspective.
Yeah. So, we have to address, especially like I said, for people with PCOS, the majority have insulin resistance. And it's a little bit different than somebody who may have insulin resistance due to perimenopause alone or due to some other condition. And I'm going to explain why. So insulin has multiple functions, right? And one of its main functions is to allow glucose, which is our blood sugar, to enter the cell so you have energy for your cells. And the other main function is that it signals the cells to produce the things that cell is supposed to produce, whether it's enzymes, other proteins, or hormones. Insulin binds to your cell. It tells your cell to utilize energy, and it tells your cell to it is that your cell is supposed to do, right? Who have insulin resistance. The resistance is only in that function where so it's limiting the appropriate use of glucose or energy. But that's the things that it's supposed to produce, like hormones, is still intact. And so that's why for PCOS, and I really can't think of another condition that functions, having insulin resistance prevents proper energy utilization, but to produce what they need to produce. And that's really why people may experience brain fog, mood changes, and weight gain because that metabolic piece is impaired, but the cells can still produce things like testosterone. It's because of that dual function that insulin has. And that is very specific to other types of insulin resistance, because otherwise everybody with insulin resistance or everybody with diabetes, type 2 diabetes, would have PCOS. And we know that that's not true. Okay. Now, we need to address the insulin resistance because when somebody has insulin resistance, the pancreas responds by making more insulin, and that makes those hormone production really just be like go on overdrive, right? And we produce in some people more cortisol. And so we need to address the insulin resistance. And that's why metformin is recommended. And so this is what you're asking me, what is my opinion and how do I approach it? So I will approach my patient and say, hey, it looks like you have insulin resistance. We've demonstrated by these lab tests, sometimes utilize appears that you have insulin resistance, which is very common in PCOS. These are all the tools that we have in the toolbox to approach it, right? We have nutrition, many, many different nutrition strategies. Improve insulin sensitivity on one side, but also minimize the overproduction of insulin on the other side. And there's different medications and supplements. So we could, you mentioned metformin. It have some side effects, but by and large, it's a generally safe medication and can be very effective. But there are alternatives, right? Inositol, a very good alternative. It's been demonstrated non-inferior, meaning it's not inferior to metformin. One person may respond better to metformin, one person may respond better to inositol. Some people may use them together. Some people may find they have more side one or the other. And so we have different options and there's pros and cons. And then now we have the GLP-1 agonists, right? Which improve insulin sensitivity and help people with appetite and help people with weight reduction. And so, there are all these different options. We talk about the pros and cons. It really depends on what people's goals are. It depends on where in their life they are. They like, again, family planning, not family planning. What other underlying medical conditions do they have? Some of my patients with PCOS appetite at baseline, right? And nobody believes them because they may be they may be dealing with obesity, but nobody believes them that they have a poor appetite. Well, what happens when you take a GLP-1 agonist? Then your appetite really is decreased. So that may not be the appropriate treatment for that person. And so maybe somebody struggles the GLP-1 agonist, but some people do amazing on it, right? And so it really depends. And some people have coverage for it and some people don't have coverage for it. And it's not, it's an expensive medication. So we have to tailor the approach and nutrition, inositol, which it's falls in the supplement category, but really is an effective treatment. Metformin, GLP-1 agonists, continuous glucose monitoring to personalize people's nutrition so that they understand how their body, utilizes specific foods, and so they all can be effective.
And speaking of this, is a great question, Jackie's question. So, and this is something I've been actually thinking about as well. I just never haven't done it yet. Jackie said, I'm considering the glucose monitor from Aspect Health. What are the benefits of using apps and monitors for someone with PCOS?
Yeah. Available to us. You have to know what to do with the data. of these different apps, Aspect Health, which is who I'm involved with, but there's others that are really great that have people who are knowledgeable, and there are others that are not so great. That really I find the values that they're using or their normal ranges are very restrictive, maybe not so appropriate for somebody with PCOS. They don't take into consideration that actually going long periods of time or under eating may lead to something called reactive hypoglycemia, that when the blood sugar goes low, that actually worsens PCOS symptoms. And so you need to know what you're doing with the data, and you need somebody that can help guide you. It's an incredible tool for personalization as long as you know what to do with that information. Now, the other caveat I have around CGMs, if somebody has any experience in the past or any history of an eating disorder, restrictive eating behaviors, sometimes people can then, get a little too about their blood glucose on their CGM. And that's just sort of changing, swapping one sort of restrictive behavior for another type. And in those, so I always screen for history of eating disorders or current eating disorders before anybody uses CGM, because you don't want to contribute to that in a different way. I forgot somebody's coined a term for that, maybe glucorexia, something like that, a new term, just to, really appreciate that is a risk for people. So great. I'm a person who loves all the data. I love personalized health data. I think we're just in this era where we really can help ourselves be our best selves. But you have to know what it is that you're going to do with the data that you gather. And I'm not going to name names, but there are some of the apps out there that really are very restrictive in terms of what glucose levels they deem acceptable, and there's no clinical basis for it. There's no evidence to suggest that really that for people, and so you got to be careful.
I must say now I kind of wish you name it, but so I don't consider them, but I understand. And Jackie, so you good?
You can ask me, yes. And feel free to reach out to me in private.
Yeah. But I think, I think now there are just so many different technology that helps us track some of these things and quantify. So I think that's great. And there are a lot of like test stuff out there as well. So I think that's something that probably have a whole nother section about what kind of like test that gets delivered to you that is like good or not. And especially with the perimenopause, it's very symptom led. So, it's been tricky, but I think that innovation is happening. So I think we're probably going to see and hear more about sort of test kits and things like that. But I think there needs to be a whole nother education about all of that.
I agree.
Would love to you know, hear from you. Are there any like good resources or books or something like that that you can recommend? Of course, like people should find you on social, and then you can find because you do a lot of educational content. And thank you, Marina, for sharing Dr. Faris's social. So for folks who you're not following her, then check her out. She does do a lot of educational bits. But are there any more resources, books, and things like that that you could like just share with us so that we can consider at our own leisure?
Yeah. There's certainly people that I follow and I read. I mean, there's the PCOS Awareness Association, there's PCOS Con, there's an app called Ask PCOS, which is out of Australia. The Monash University is like so way far ahead of us in terms of their PCOS research and education. We have the incredible Angela Grassi here with us today in our audience. She is a wealth of knowledge around PCOS nutrition. She's a just incredible advocate and dietitian. And so I've been a big fan and follower of hers for a long, long time. And so if she says you should follow somebody, then we should take her recommendations as well. And so I think those are some really out there.
Really helpful. Another question that I wanted to ask you earlier, but wanted to layer ethnicity. Have you seen anything when it comes to sort of PCOS, perimenopause, across the women who are Caucasian, Asian, African American? Do you see anything from your practice or any research that you came across? Just curious, because there's not a lot of research to begin with in women's health, and they were talking about two topics that are not totally widely understood. So just curious.
Well, yeah, we know that people of different ethnicities experience mentally, right? And so I don't know, so menopause and perimenopause, and if you all haven't seen the M Factor, which is the documentary about menopause, they touch on that a great deal about some of the ethnic differences in people and their PCOS experience in terms of, we just think of hot flashes, right, as like the ultimate menopausal symptom, but not everybody experiences hot flashes, right? And so, like for example, in the documentary, they cite that women of Asian descent may experience more cognitive and sort of joint pain, and so different symptoms than somebody who may experience more hot flashes. And so everybody's experience can be a little bit different. And then sometimes it's in symptom reporting and what people are comfortable reporting in terms of, sexual side effects and sexual symptoms of perimenopause. And so we definitely need to understand that as well. And just as well, in terms of PCOS, there are there are different experiences among different groups. It seems that people of Central and American descent who have PCOS have really some more profound insulin resistance. This also may be true for people of South Asian descent at lower BMIs than other ethnic groups. And we don't use BMI as we shouldn't be using BMI as an individual measure of people's health, right? It's a population term. And so yes, people do experience PCOS a little bit differently. African American women experience some more of the dermatologic and androgenic symptoms like hirsutism and acne. So yeah, all different and experiences across the different ethnic groups for both PCOS and perimenopause as well.
Amazing. No, thank you so much. And thank you, everybody. This was fantastic. And I learned a lot. And we're definitely going to surface this recording. I know there's some spotty places, but thanks for your patience. And yeah, please, follow, check out some of the resource things that Dr. Faris talked about. And also from our end, if you like, then follow us at nabi.life, Nabi with double N. We do a lot of educational bits as well about perimenopause. We really want to redefine how women experience perimenopause as early as in their 30s. So we're all in it to change this narrative together. So yeah, thank you so much, Dr. Faris, once again.
Thanks for having me. My pleasure.
Thank you, everybody.
Thanks everybody for attending and all your great questions.
Thank you. Thank you.
Bye.
Bye, Dr. Faris. Thanks.